Thanks very much for having me. Yes, my name is Giles. I am a surgeon. I come in peace. I sit on a number of sort of councils throughout the UK which are really important to surgeons, but not really important to many other people. But the reason I put this up is because hopefully by the end of this sort of 20-minute talk, you'll understand that I'm trying to drive through a change, and I'd really like everybody else to get involved with me and know that we've got the backing of these quite important ASGBI, Orgis and NFAS are quite important sort of acute surgery, general surgery, liver and pancreatic surgery societies. I'm a surgeon. I'm not going to teach you to suck eggs, but clearly gram-negative sepsis is like really important. And I sat in a talk just like this a few years ago, and I just saw all these devastating facts coming up about gram-negative sepsis killing thousands of people, gram-negative sepsis being one of the biggest drivers in AMR, but more importantly, more worryingly, that sort of E. coli statistic was saying that it was on the increase and we needed to get on top of it. So the government, as I know you all know, tried to reduce this sort of reduction of gram-negative sepsis and a big sort of national program. And I know that the timeline slipped a little bit over the years, but they're aiming for a 50% reduction by sort of 2024, right? In 2019, they put out a 5-year sort of plan saying, guys, let's all come together. What can we do about this? What novel ideas are there out there to try and help reduce gram-negative sepsis rates? And one thing that really struck me when I was listening to a professor of microbiology from the Marsden was that the HPB cohort, that's sort of like my manor, was quite a big group. And I'd never really sort of understood that, never really appreciated it. So I went to our own stuff. I work alongside Lisa Butcher, who I'm sure many of you will know. And Lisa basically helped me grab out, we just took E. coli. It's important to us in HPB, but also obviously as a GNS. And you'll see that the HPB group is massive. And actually, it's really big. And I'll tell you, as surgeons, we're not really doing much about it. We haven't really appreciated it. And what I kept getting told is, yeah, but Giles, it's all cancer. They're all dead in a few months, so what does it matter? Well, it's pretty down, so I'll try and lighten that up a little bit. It's not, basically. And I sat there with my sort of emergency surgery head on, and I had this sort of light bulb moment where, do you know what? It's not cancer. It's about gallbladders. In my unit in Oxford, we're a large surgical unit. I'll throw some data up in a minute, which you can sort of look at. But we see a lot of infected gallbladders coming in. And if I speak to you and give the definition that there's a blind-ending structure that gets inflamed and angry and needs to be removed, am I talking about the appendix, that top picture, or am I talking about a nasty gallbladder, the bottom picture? Either way, they're both evil and they need to come out. So there's like guidelines. So when you start looking this, right, you go down that rabbit hole, right? You start thinking, well, can we do something here? What about if we get early intervention in these people? Has anyone looked at it? Well, they have. The NICE guidelines, 2014. It's nearly 10 years ago. They were saying that if you've got an infected gallbladder in acute cholecystitis, you should be taking the gallbladder out on that sort of index of admission, ideally, but definitely within 1 week. Orgis, one of those big societies that I was talking about, helped put this together in pancreatology, where people that suffer with gallstone pancreatitis should have their gallbladder out on that index of admission. Orgis, again, went further to say that if you've got acute cholecystitis, don't wait a week, keep the patient in and take the gallbladder out ideally within 72 hours. Now, the reason that we say within 72 hours is because after 72 hours, trying to take the gallbladder out when it's angry and inflamed causes a lot of stress. It's really hard to do. So you've got to have surgeons that are used to dealing in a sort of hostile environment like that, and have the experience to take the gallbladder out safely. Most HPB surgeons can do that, and now most acute general surgeons are sort of with an interest in gallbladder disease can take nasty, hot, perforated, necrotic, gangrenous, however you want to describe it, gallbladders out in the same way that we take appendixes out. So in Oxford, we see about 15,000 patients a year through my surgical emergency unit, makes us one of the largest in the UK. It's Prof. Wilcox down here from Leeds. They're sort of up there with us as well. We have a friendly battle to see who's the best. Currently, I think it's actually Leeds, but anyway, we'll move on over that. But 40% of the cohort of patients coming through are biliary related. We do about 1,000 gallbladders a year, elective and emergency in Oxford. When I started, we used to do about 80 to 100 a year. Now we do about 400 to 450. So 45% of our gallbladders are now done in the acute setting. We changed our practice. What we said, or basically what I dictated, was if a patient comes in with acute cholecystitis, gallstone pancreatitis, obstructive jaundice secondary to gallstones, or they just are having multiple episodes of symptomatic gallstone disease. Ow, 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 my gallbladder's hurting. We get a scan, normal, blood's normal, but that pain's not settling down. We manage it as if it's acute cholecystitis. So those 4 groups of people, really easy to identify. Any sort of junior surgeon, junior doctor by and large, can pick those out. And what we say is those patients aren't going home until they've had their gallbladder taken out. And look at what happened. 2015-16, we got up to a peak, and that first dip down is when we significantly ramped up our hot gallbladder service. You then see that there's another peak up. Oh, Giles, it failed. No, we got told to stop doing it because we were overwhelming the system, and we just didn't have the infrastructure there. So the management turned around and said, no, you can't keep doing this, stop. And look what happened. We instantly, our gram-negative sepsis rates suddenly went back up. So the mighty Lisa Butcher backed me in my trust and said, no, this guy's got to operate. And look, that downward trend. It's much better than that now, but in order to sort of formalize that, we did a formal study, obviously, and this paper basically comes out to say, look, let's just take a really good cohort of acute HBB patients and see if there's anything within those patients that back up our feeling that early intervention of gallbladders results in a reduction in gram-negative sepsis rates long term. So if someone turns up, angry gallbladder, we take it out, does that reduce the rate of gram-negative sepsis? So we went through all the notes, right? 433 patients, all electronic summaries. It was all done at quite high level. So it was done by me as a consultant surgeon, another consultant surgeon, and then a senior fellow along. And the reason that we deliberately created this database at a high level is that we had the ability to be able to interrogate the notes and pick out the little nuances that the GPs had written before that gave us a clue that, guess what, this patient actually had symptomatic gallstones, the GP just didn't recognize it. Or the patient presented to ED with right-sided pneumonia. It weren't right-sided pneumonia, it was an inflamed gallbladder that was causing a right-sided chest infection, a secondary pneumonia due to the hot gallbladder. And we were able to tie that out. We thought it was important to get the data set accurate, so it needed quite experienced people. So we got 433 people. We discharged 45 out because actually they weren't gram-negative sepsis related to HBB. We're left with 388 cases. Of those, look at that. It's not about cancer, is it? Yeah, sure. Some are, but by far the majority were not HBB cancers. They were benign disease. And of those 305 cases of benign disease, look at that. the majority is gallstone disease. Just to put that back, other benign disease, it can be like cysts and things like that. There are other things that can cause biliary pathology. So we looked at those 282 that were gram-negative, that were gallstone-related disease. And 150 odd of them, they had gram-negative sepsis at the first time of presentation. So guess what? They had never had a problem. Suddenly, lovely Sunday lunch, ow, my gallbladder's got angry. You can't do anything about it. They've gone in. You can't predict the future. So let's just kick those to one side. But then we're left with 124 cases where we knew they had gallstones. And those gallstones were symptomatic, and then they presented with gram-negative sepsis. We actually, of those cases that presented, 101 had just had symptomatic. They hadn't had any other problems. All we were doing, and by we I mean the NHS, so that's GPs, ED, surgeons, medics, everybody was just watching those patients with them rubbing their right upper quadrant going, oh, it's my gallbladder, gives me a bit of jip after I have a big fatty meal, don't worry about it. I think we should. Because if we had taken those symptomatic gallstones and taken them out, we would have reduced our gram-negative sepsis rate by 32%. That's not bad when we're trying to reduce by 50% in a cohort of patients that's got nothing. So people stood up and sort of thought, blimey, that's pretty good. And look at that. We can reduce, if we operate, we reduce the rate of gram-negative sepsis by over 4-fold by taking the gallbladder out early. This is the buzz points. So now, think about it. A patient turns up. They have symptomatic gallstones. They have an inflamed gallbladder. We are not going to just let them go home, treat them with antibiotics, and keep our fingers crossed that everything's going to be all right. Because 30% of them are not going to be all right. And it's a gram-negative sepsis problem that we have a solution to. Everything I've just said there, I can see some people very kindly taking pictures. You can have this presentation, it's no problem. But it's all written in that. That's the picture you want to take, if anything, because it's the reference for where we publish that. And I will give credit to everybody in there, especially Lisa Butcher, because she's helped me on lots of projects. And if you come and see me a bit later, I'm giving another talk about SSI reduction strategies. But yeah, and Lisa Butcher was there. It's the coming together of IPC and surgery. It can really, really dominate and change things. But the question here, and I'm trying to get us back on time, the question here is, what are the next steps? What do I really, really want you guys to go out and try and do? And the first thing is, I want you to go out and try and find an interested HPB acute surgeon, someone who likes taking gallbladders out. So in Leeds, I know, right? In Leeds, you got Giles Toogood, an absolute legend, president of Orgis, a god amongst all the surgeons that we look up to. He's driving this forward in his unit, I know. Once you've got that surgeon, really grab onto him, and then take that surgeon, and what you want to do is you want to educate the GPs. And the GPs really have to take ownership here, because lots of people present to GPs with symptomatic gallstones and are just sent away. If patients present multiple times to their GPs, they're given antibiotics and sent away. I know that because I've gone through 433 notes and I can see the story time and time again. The message is really clear, really, really clear. You and the surgeon stand there next to the GP and say, any symptomatic gallstones, can you just send them our way for review before they get infected and become a problem? You need IPC are so powerful in changing surgeons' behavior, because what they are able to do are to bridge the gap between the hostile, aggressive surgeon and the trust management, who are probably equally as bad. But they sit in the middle, and they can explain to the management why it is so important that we get on top of this as soon as possible. And the surgeons will then turn around and love the IPC people, because guess what? They've helped me operate on more people, and what I do is I like to cut. But the trust are going to stand there and say, but hang on, what's in it for us? I appreciate it's a government target, there's lots of government targets, come on. I'll tell you what it's about. Hot gallbladders, as you can see, are a common problem. 40% of our patients coming through a problem. If you give them antibiotics and go home, they have a 40 to 60%, so let's just call it half, a 50% chance of coming back into hospital with the same problem before they get a definitive operation. So why would you do that? That is just an absolute nuts way to manage things. Yeah, we're going to kick it down the line and then hope that nothing happens before they come back. All the data, multiple papers say they will bounce back in. It's only got worse since COVID. With waiting lists, I don't know what it's like. In Oxford, to get an elective gallbladder, it's over a year. There's no way someone presenting with acute cholecystitis will hold out for a year. They just won't. They'll be back in. And that's a drain on our resources. The other thing is, if you operate on these acute cholecystitis patients within 24 hours, they go home within 24 hours. So I see patients that come into my unit on a Monday, we can get them ultrasound scanned, you've got nasty gallbladder. If we can take them out that day, they're going home the next day. But actually what we now do is typically operate first thing in the morning on the Tuesday, and they go home later on the Tuesday. It's 48 hours. Or they can sit in a bed getting IV antibiotics, treating a problem that has a surgical solution where we don't give any more antibiotics. Once that gallbladder's out, it's done. So it ticks the whole AMR, antimicrobial stewardship box, in a massive way. But the person that we're all here to really satisfy is the financial director of your trust. And I'm telling you now, hot gallbladders, they bring the money. If I do an elective gallbladder, I get about £1,800. If I do a hot gallbladder, I get about £5,000 to £6,000. Now, everyone's going to turn around and say, oh, but we're on a block contract. We can only do 1,000 gallbladders a year. Acute surgery is exempt from all of that. So bring it in and bring the money. So my trust, in my department, we went from losing about £700,000 a year. So my emergency surgery unit, in a year, we on average were £700,000 down. Since going up and increasing our hot gallbladder, we're about 1.2 million in the black. The trust can't do enough for us at the moment. I mean, it's not been all that easy, lots of arguing and stuff like that. But by and large, the trust get it. And the main things, well, the final thing that really made them get it was the fact that it brought in a lot of money. So at least at the end of the day, you can turn around and go, cool, clinical excellence, not interested in that. Patient flow, not interested in that. They always listen to the money. So thank you very much.